It is well accepted that high-intensity statin therapy reduces total and cardiovascular risk mortality. However, concerns have emerged recently related to the diabetogenicity of statins, including a moderate intensity-dependent increase in new onset of type 2 diabetes mellitus. This is Peter Kokinos. I'm a professor at Rutgers University, Department of Kinesiology and Health. I'm also affiliated with the Veterans Affairs Medical Center and George Washington University. I would like to thank the Mayo Clinic Proceedings for this unique opportunity to present the findings of our study entitled Diabetes Incidence According to Statin Intensity, Regimen, Body Mass Index, and Cardiorespiratory Fitness. This article is scheduled for publication in the November 2025 issue of Mayo Clinic Proceedings. I would also like to acknowledge the co-investigators for their contribution to this study. The cohort of this study is part of the Ethos cohort, a prospective data set of over 831,000 U.S. veterans nationwide. From the Ethos cohort, we identified over 311,000 individuals treated with statins with no evidence of diabetes prior to the initiation of statin therapy. The mean age of the cohort was 61 years. All completed a standardized exercise treadmill test with no evidence of ischemia. Based on the age, sex, and peak METs achieved on this standardized test, we established 5 fitness categories: least fit, low fit, moderate fit, fit, and high fit. We also classified them as normal weight, overweight, obese class 1, and obese class 2 and 3 based on standardized body mass index classifications. Finally, we classified them according to the intensity of statin regimen as low intensity and high intensity. During the median follow-up time of 11 years, 56,994 individuals developed diabetes. After adjusting for all confounders, our findings are as follows. The risk of developing diabetes was 23% higher in patients treated with high-intensity statins compared to those on low-intensity statin therapy. When we assessed the impact of body weight on the statin-related risk of diabetes, we observed a progressively higher risk of diabetes with higher BMI, as illustrated in Figure 2. Furthermore, the increased risk was more pronounced in those treated with high-intensity statins within each BMI category. We examined the risk of diabetes according to the fitness status of the individuals. Shown in Figure 3, we observed a progressively lower risk with higher fitness on both low and high-intensity statin therapy groups. Compared to the least fit group, the reference group, diabetes risk was 18% to 57% lower for those with a peak exercise capacity of 7 METs or higher. This pattern was similar for both low and high-intensity statin therapy groups and for all BMI categories, as shown in Figure 3 for the intensity groups and Figure 4 for the BMI groups. Finally, we assessed the interaction between statin intensity therapy and fitness. These findings are illustrated in Figure 5. Note that the risk of diabetes declined progressively with increasing fitness for both statin treatment groups. However, the decline was substantially more pronounced in those treated with low-intensity statins. Nevertheless, for patients treated with high-intensity statins, the blue bars, and peak exercise capacity of approximately 8.5 mets or higher, these are the moderate fit, and high fit groups, the diabetes risk in these groups was significantly lower compared to the least fit patients on low intensity statin regimen. This is the green bar, the reference group. This study makes two unique contributions to the literature. First, our findings support the concept that the statin-related, intensity-dependent increased risk of diabetes, also reported by previous studies, was amplified by excess body weight expressed as BMI. Second, this increased risk was moderated by high cardiorespiratory fitness, regardless of body weight or statin therapy regimen. Therefore, strategies to manage body weight and, more importantly, improve cardiorespiratory fitness in patients on high-intensity statins should be emphasized by healthcare professionals to potentially lower the risk of diabetes. The fitness level associated with a significantly lower risk of diabetes was approximately 7 to 10 mets. This level of fitness is achievable by most middle-aged and older individuals by following the American College of Sports Medicine and American Heart Association exercise guidelines, which recommend engaging in moderate intensity exercises such as brisk walk for 150 to 300 minutes per week. We should all be aware that exercise carries an inherent risk of adverse cardiac events, especially for those who have been relatively sedentary or have certain medical conditions or start exercising by doing too much too soon. Therefore, it is advisable for patients to consult with their healthcare provider before engaging in physical activities of moderate or high intensity. It is essential that healthcare providers encourage their patients to start exercising at a level that is comfortable for them and progress gradually, aiming to reach the goal of 150 minutes of exercise per week. A recommended approach is as follows. Start with a brisk walk for 10 minutes per day, most days of the week. Add 1 to 3 minutes to each exercise session after week 2. Add a day to your week after week 4 and another day after week 8. Following this exercise routine will result in 150 minutes or more of exercise per week within 10 to 12 weeks. Finally, the clinically relevant message of our findings is that increased cardiorespiratory fitness modulates the statin-related risk of developing diabetes, regardless of BMI or statin intensity regimen. Although we cannot attribute causation due to the epidemiological nature of our study, the strength of our findings strongly support that randomized controlled trials are needed to further examine the impact of cardiorespiratory fitness on the statin-related risk of developing diabetes. Thank you for your attention.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us Our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.